Welcome to Pediatric Case Review, Musculoskeletal Series. Today we present a comprehensive case-based review of the causes of arthritis in children. This lecture is designed for general pediatricians and covers 16 carefully crafted clinical cases addressing the major causes of joint inflammation in pediatric patients. We will walk through septic arthritis, juvenile idiopathic arthritis subtypes, acute rheumatic fever, pathophysiology, laboratory investigations, imaging, treatment strategies, and long-term complications. Let us begin. Case 1. A 4-year-old boy presents with sudden onset, right knee swelling with pain for 3 days. He refuses to walk. His temperature is 38.2 degrees Celsius. There is no trauma history. On examination, the knee is warm, tender, with moderate swelling. X-ray shows joint space widening of the right knee. What is the most likely diagnosis? Option A, juvenile idiopathic arthritis. Option B, transient synovitis. Option C, septic arthritis. Option D, reactive arthritis. The correct answer is option C, septic arthritis. The classic triad of fever, acute joint swelling, and non-weight-bearing demands immediate action. X-ray showing joint space widening is an early sign of significant joint effusion. The most common causative organism in children is Staphylococcus aureus. This is an emergency because delayed diagnosis leads to irreversible joint destruction. You must aspirate and treat within 24 hours. The clinical pearl to remember is that fever plus acute joint swelling plus non-weight-bearing equals septic arthritis until proven otherwise. Case 2. A 3-year-old girl has had left knee swelling for 6 weeks. She walks with a limp but denies pain. She has no fever. On examination, there is mild effusion with no erythema and no warmth. Her anti-nuclear antibody is positive with a homogeneous pattern. What is the most likely diagnosis? Option A, Lyme disease. Option B, hemophilia. Option C, oligoarticular juvenile idiopathic arthritis. Option D, systemic lupus erythematosus. The correct answer is option C, oligoarticular juvenile idiopathic arthritis. This is the most common subtype of juvenile idiopathic arthritis, typically affecting young girls between 1 and 6 years of age. It involves 4 or fewer joints, especially large joints like the knee and ankle. Anti-nuclear antibody positivity with a homogeneous pattern carries a high uveitis risk. The duration beyond 6 weeks distinguishes it from reactive or transient causes. Importantly, the swelling is often painless, and the child may not complain despite visible effusion. Slit lamp screening every 3 months is mandatory in high-risk anti-nuclear antibody-positive children under 6 years of age to detect silent uveitis. Case 3. A 6-year-old boy has been sick for 2 weeks. He has high spiking fevers every evening. A salmon-colored rash appears with the fever and disappears when he is afebrile. He has developed bilateral knee pain over the last few days. Erythrocyte sedimentation rate and C-reactive protein are elevated. There is no recent infection history and no trauma. The fever preceded the joint symptoms. What is the most likely diagnosis in this child? Option A, viral illness. Option B, Kawasaki disease. Option C, tuberculosis. Option D, systemic juvenile idiopathic arthritis. The correct answer is option D, systemic juvenile idiopathic arthritis. The key diagnostic features include daily spiking fever, typically in the evening, reaching 39 degrees Celsius or higher. The evanescent rash is salmon pink, migratory, and appears with fever. Organomegaly with hepatosplenomegaly and lymphadenopathy is common. Laboratory markers show erythrocyte sedimentation rate at 105 mm per hour, C-reactive protein at 3.2 mg per deciliter, white blood cell count at 18,000 per microliter, and ferritin at 850 nanograms per milliliter. Ferritin above 500 nanograms per milliliter is a red flag for macrophage activation syndrome, requiring immediate escalation. Always rule out infection and malignancy first. Case 4. A 5-year-old boy presents to the emergency department with a 2-day history of limping and refusal to bear weight on his right leg. His mother reports no trauma. He appears uncomfortable when moving his right hip. Temperature is 38.6 degrees Celsius. The hip is held in flexion, abduction, and external rotation. Erythrocyte sedimentation rate is 52 mm per hour. Which physical examination finding best differentiates septic arthritis from transient synovitis? Option A, mild tenderness on gentle palpation of the hip. Option B, localized warmth over the hip joint. Option C, non-weight-bearing gait with severe pain on passive range of motion. Option D, hip held in a position of comfort, flexion, and external rotation. The correct answer is option C, non-weight-bearing gait with severe pain on passive range of motion. In septic arthritis, non-weight-bearing is present in 95% of cases compared to only 35% in transient synovitis. Pain on passive range of motion is severe in septic arthritis, but only mild to moderate in transient synovitis. Fever is present in 82% of septic arthritis cases, but is usually absent in transient synovitis. Erythrocyte sedimentation rate above 40 mm per hour and white blood cell count above 12,000 per microliter support septic arthritis. The key discriminator is that non-weight-bearing plus fever plus severe passive range of motion pain equals septic arthritis until proven otherwise. Early aspiration and intravenous antibiotics are critical. Case 5. A 7-year-old boy has been having daily spiking fevers every evening for 3 weeks. His mother reports a pink rash that appears on his chest and arms during the fever episodes and disappears afterward. On examination, temperature is 39.4 degrees Celsius, enlarged liver and spleen are palpable, swollen cervical lymph nodes are noted, and bilateral knee swelling is mild. Laboratory results show erythrocyte sedimentation rate at 112 mm per hour, C-reactive protein at 4.1 mg per deciliter, and ferritin at 920 nanograms per milliliter. Which systemic sign is most specific for systemic onset juvenile idiopathic arthritis? Option A, pallor and fatigue. Option B, peripheral lymphadenopathy only. Option C, hepatosplenomegaly combined with spiking fever and evanescent rash. Option D, elevated erythrocyte sedimentation rate alone. The correct answer is option C. The combination of hepatosplenomegaly, spiking fever, and evanescent salmon pink rash is the pathognomonic triad of systemic onset juvenile idiopathic arthritis. Hepatosplenomegaly reflects reticuloendothelial activation. Daily spiking fever reaching 39 degrees Celsius or higher persisting for 2 or more weeks is a mandatory diagnostic feature. The evanescent rash appears and disappears with fever spikes, which is a hallmark absent in other diagnoses. The red flag algorithm is as follows. When you see fever plus rash plus organomegaly, check erythrocyte sedimentation rate, C-reactive protein, ferritin, lactate dehydrogenase, and triglycerides. If ferritin is above 500 nanograms per milliliter, consider macrophage activation syndrome and make an urgent rheumatology referral. Case 6. A 5-year-old girl with known oligoarticular juvenile idiopathic arthritis diagnosed 8 months ago presents for a routine follow-up. She has no eye symptoms, no redness, no pain, and no vision complaints. Her antinuclear antibody is positive with a homogeneous pattern. She had 3 or fewer joints affected since diagnosis. Her last ophthalmology visit was 12 months ago. Which ocular complication is most commonly associated with this clinical profile? Option A, glaucoma. Option B, diabetic retinopathy. Option C, chronic anterior uveitis. Option D, optic neuritis. The correct answer is option C, chronic anterior uveitis. This is the most common and most dangerous ocular complication of oligoarticular juvenile idiopathic arthritis. It is asymptomatic, with no pain and no redness, which makes screening essential. It carries bilateral risk even if only one eye is involved initially, and affects up to 20% of oligoarticular juvenile idiopathic arthritis cases. Slit lamp examination shows chorotic precipitates, flare and cells, and posterior synechiae. The screening protocol requires antinuclear antibody-positive children under 6 years with oligoarticular disease to have slit lamp examination every 3 to 4 months. If uveitis is detected, start topical corticosteroids and add mydriatics if synechiae are present, with monitoring every 6 to 8 weeks. The goal is to prevent band keratopathy, cataracts, and glaucoma. Case 7. A 10-year-old boy presents with a 2-week history of joint pain affecting his knees and ankles, which have been migratory in nature. He had a sore throat 3 weeks ago that was not treated. On auscultation of the heart, the physician detects an abnormal finding. Temperature is 38.4 degrees Celsius. Antistreptolysin O titer is elevated at 680 international units per milliliter. Erythrocyte sedimentation rate is 78 millimeters per hour. Heart rate is 110 beats per minute. Which cardiac finding is most characteristic of acute rheumatic fever in this child? Option A, fixed split-second heart sound with pulmonary ejection click. Option B, pericardial friction rub at the left sternal border. Option C, apical pansystolic murmur radiating to the axilla. Option D, continuous machinery murmur below the clavicle. The correct answer is option C, apical pansystolic murmur radiating to the axilla, which represents mitral regurgitation. The mitral valve is the most commonly affected valve in acute rheumatic fever. Arthritis occurs in 40 to 60% of cases. Ascough bodies are pathognomonic granulomatous lesions found in the myocardium. A new-onset pansystolic murmur at the apex indicates mitral regurgitation. The Jones criteria major criteria include carditis, either clinical or subclinical, migratory polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Diagnosis requires 2 major criteria, or 1 major plus 2 minor criteria, plus evidence of prior group of streptococcal infection. Echocardiography should be performed in all suspected cases, as subclinical carditis may be missed on auscultation alone. Case 8. A 7-year-old girl has had persistent swelling and morning stiffness in both wrists and knees for the past 4 months. She has no fever. Anti-nuclear antibody is positive. Her pediatric rheumatologist explains that her immune system is attacking her own joint tissue. What is the primary immunological mechanism responsible for chronic synovial inflammation in juvenile idiopathic arthritis? Option A. Immunoglobulin-mediated hypersensitivity reaction to synovial antigens. Option B. Neutrophil infiltration secondary to direct bacterial invasion. Option C. T-cell-mediated autoimmunity targeting the synovial membrane. Option D. Complement cascade activation via the classical pathway. The correct answer is option C. T-cell-mediated autoimmunity targeting the synovial membrane. Cluster of differentiation: 4 positive T cells recognize self-antigens in the joint synovium, triggering a cascade of pro-inflammatory cytokines that drive chronic joint destruction. Tumor necrosis factor alpha drives synovial hyperplasia and Ponn's formation. Interleukin-1 activates osteoclasts, leading to cartilage and bone erosion. Interleukin-6 causes systemic inflammation, fever, and the acute phase response. These cytokines are the therapeutic targets of biologics used in juvenile idiopathic arthritis, including tumor necrosis factor inhibitors, interleukin-1 blockers, and interleukin-6 inhibitors. Understanding this pathway is essential for selecting appropriate biologic therapy. Case 9. A 9-year-old boy presents with painful swelling of both knees and ankles for the past 10 days. 3 weeks ago, he had a sore throat treated with over-the-counter medications only. He now has a low-grade fever, migratory joint pain, and his mother reports he sometimes complains of chest discomfort. Investigations show elevated antistreptolysin O titer, throat swab positive for group A beta-hemolytic streptococcus, electrocardiogram with mild PR prolongation, and erythrocyte sedimentation rate at 78 mm per hour. What molecular mechanism best explains why cardiac and joint tissues are targeted after streptococcal infection? Option A. Immunoglobulin-mediated hypersensitivity to streptococcal exotoxins. Option B. Complement activation via the mannose-binding lectin pathway. Option C. Streptococcal M protein and peptidoglycan share structural homology with human cardiac myosin, triggering cross-reactive antibodies. Option D. Direct bacterial invasion of synovial tissue by group A streptococcus. The correct answer is option C. The mechanism is molecular mimicry. Group A streptococcal M protein shares structural homology with human cardiac myosin. Following pharyngitis by group A streptococcus, the immune system produces anti-M protein immunoglobulin G antibodies. Due to cross-reactivity, these antibodies mistake cardiac myosin for M protein, a process called molecular mimicry. This autoimmune attack leads to carditis and valvulitis, with the mitral valve most commonly affected. The key insight is that the immune system cannot distinguish M protein from cardiac myosin, and this mistaken identity drives rheumatic heart disease. This is why treating streptococcal pharyngitis with antibiotics is essential for prevention. Case 10. A 7-year-old boy presents with 3 weeks of daily spiking fevers reaching 39.5 degrees Celsius each evening, accompanied by a salmon-pink evanescent rash appearing during fever spikes. He has developed bilateral knee and wrist pain over the past week. On examination, hepatosplenomegaly and cervical lymphadenopathy are noted. His mother reports significant fatigue and weight loss. Laboratory results include erythrocyte sedimentation rate 110 mm per hour, C-reactive protein 4.8 mg per deciliter, white blood cell count 19,500 per microliter, hemoglobin 9.2 grams per deciliter, platelets 480 times 10 to the 9th per liter, serum ferritin 920 nanograms per milliliter, and anti-nuclear antibody negative. Which laboratory finding is most supportive of systemic juvenile idiopathic arthritis and serves as a red flag for macrophage activation syndrome? Option A. Normal C-reactive protein and erythrocyte sedimentation rate. Option B. negative antinuclear antibody with low platelet count. Option C, elevated serum ferritin above 500 nanograms per milliliter. Option D, leukopenia with elevated lymphocytes. The correct answer is option C, elevated serum ferritin above 500 nanograms per milliliter. Ferritin above 500 is highly suggestive of systemic juvenile idiopathic arthritis. Ferritin above 1,000 nanograms per milliliter should raise concern for macrophage activation syndrome. In systemic juvenile idiopathic arthritis, ferritin rises out of proportion to other inflammatory markers. The diagnostic algorithm proceeds as follows. Fever plus rash plus organomegaly should prompt checking erythrocyte sedimentation rate, C-reactive protein, ferritin, lactate dehydrogenase, triglycerides, and complete blood count. If ferritin exceeds 500, suspect macrophage activation syndrome and start intravenous dexamethasone. The International League of Associations for Rheumatology classification criteria for systemic juvenile idiopathic arthritis require mandatory fever plus arthritis plus at least one accessory feature, with exclusion of other causes. Case 11. A 7-year-old girl presents with a 4-week history of right knee swelling and mild morning stiffness lasting 30 minutes. She is afebrile and walks with a slight limp. Physical exam reveals a warm, mildly swollen right knee with restricted flexion. No rash or lymphadenopathy. Antinuclear antibody is positive. Erythrocyte sedimentation rate is mildly elevated. The pediatrician suspects early juvenile idiopathic arthritis. Which imaging modality is most sensitive for detecting early synovitis in this child? Option A, plain X-ray of the right knee. Option B, computed tomography scan of the right knee. Option C, ultrasound with power Doppler. Option D, bone scintigraphy. The correct answer is option C, ultrasound with power Doppler. This is the most sensitive modality for early synovitis detection. Ultrasound with Doppler has high sensitivity for detecting active synovitis in real time at the bedside. Magnetic resonance imaging has very high sensitivity and excels at detecting bone marrow edema, cartilage damage, and erosions. Plain X-ray has low sensitivity and shows only late-stage changes. Computed tomography has moderate sensitivity but carries radiation risk. The first-line recommendation is ultrasound for suspected early juvenile idiopathic arthritis and magnetic resonance imaging for complex or equivocal cases. Ultrasound detects synovial thickening and hyperemia before structural damage occurs, and normal X-ray findings do not exclude active synovitis. Case 12. A 7-year-old boy presents to the emergency department with a 3-day history of severe right knee pain, inability to bear weight, and fever of 39.1 degrees Celsius. The knee is markedly swollen, warm, and exquisitely tender. He has no history of trauma or recent illness. The attending pediatrician decides to perform diagnostic joint aspiration of the right knee. The synovial fluid appears cloudy and yellow. Which synovial fluid finding best confirms the diagnosis of septic arthritis? Option A, white blood cell count less than 2,000 per microliter with lymphocyte predominance. Option B, glucose level lower than serum glucose by 40%. Option C, white blood cell count greater than 50,000 per microliter with neutrophil predominance. Option D, protein level less than 30 milligrams per deciliter with no organisms on gram stain. The correct answer is option C, white blood cell count greater than 50,000 per microliter with neutrophil predominance. Synovial fluid is classified into 3 categories. Non-inflammatory fluid, seen in transient synovitis, is clear or pale yellow with high viscosity. White blood cell count below 2,000 per microliter, neutrophils below 25%, normal glucose, and negative culture. Inflammatory fluid, seen in juvenile idiopathic arthritis and reactive arthritis, is yellow or turbid with reduced viscosity. White blood cell count between 2,000 and 50,000 per microliter, neutrophils 50 to 75%, slightly reduced glucose, and negative culture. Septic fluid is purulent or cloudy with very low viscosity. White blood cell count above 50,000 per microliter, neutrophils above 75%, markedly reduced glucose, and culture often positive for Staphylococcus aureus. Do not wait for culture results. Start intravenous antibiotics and surgical washout immediately. Case 13. A 7-year-old girl presents to your clinic with a 6-week history of painless swelling in her right knee. She has no fever, walks with a mild limp, and her parents report she rarely complains of pain. On examination, there is moderate effusion in the right knee, mild warmth, and no erythema. No other joints are involved. Antinuclear antibody is positive. Erythrocyte sedimentation rate is mildly elevated. X-ray shows no bony erosions. What is the most appropriate first-line intervention? Option A, oral prednisone daily. Option B, methotrexate weekly. Option C, nonsteroidal anti-inflammatory drugs alone, such as naproxen. Option D, intra-articular corticosteroid injection. The correct answer is option D, intra-articular corticosteroid injection. This directly targets the inflamed joint with no systemic exposure. The mechanism involves suppressing nuclear factor kappa B, which reduces tumor necrosis factor alpha, interleukin-1, and interleukin-6. Rapid remission occurs in 70 to 80% of patients within weeks. Comparing treatment options, intra-articular steroid has a remission rate of 75 to 80% with onset in days and a rare risk of local atrophy. Systemic nonsteroidal anti-inflammatory drugs have a 40% remission rate with onset in weeks but carry gastrointestinal and renal risk. Oral prednisone has 60% remission rate but causes growth suppression. Methotrexate has 55% remission rate with onset in months and risk of hepatotoxicity. The American College of Rheumatology 2019 guidelines recommend intra-articular steroids as first line for active oligoarticular juvenile idiopathic arthritis. Case 14. A 9-year-old boy with known systemic juvenile idiopathic arthritis is admitted with persistent spiking fevers for 10 days despite nonsteroidal anti-inflammatory drugs. He has new hepatosplenomegaly on examination. Ferritin is 3,200 nanograms per milliliter and rapidly rising. Fibrinogen is 1.1 grams per liter, which is low. Platelets are 78,000 per microliter and falling. Triglycerides are elevated. Which biologic agent is most appropriate for this patient? Option A, etanercept. Option B, adalimumab. Option C, anakinra. Option D, tofacitinib. The correct answer is option C, anakinra. Anakinra blocks interleukin-1 beta, which is the key driver of systemic juvenile idiopathic arthritis inflammation. In systemic onset disease with fever, rash, hepatosplenomegaly, or macrophage activation syndrome, interleukin-1 inhibition is the targeted biological approach. Etanercept and adalimumab, which are tumor necrosis factor alpha inhibitors, are less effective in systemic disease. Tofacitinib, a Janus kinase pathway inhibitor, is reserved for refractory cases only. The treatment ladder proceeds from step 1 with nonsteroidal anti-inflammatory drugs and intra-articular steroids for mild disease, to step 2 with methotrexate for persistent disease, to step 3 with anti-tumor necrosis factor agents for polyarticular disease, to step 4 with anakinra as an interleukin-1 inhibitor for systemic features or macrophage activation syndrome, and finally step 5 with canakinumab for refractory systemic disease. Start anakinra early and do not delay. Case 15. A 9-year-old boy has had poorly controlled unilateral right knee arthritis for 3 years. His parents now notice that his right leg appears longer than the left. He has no history of trauma or surgery. On X-ray, the right distal femoral growth plate appears widened and irregular. What is the most likely cause of leg length discrepancy in this child? Option A, osteoporosis from chronic steroid use. Option B, muscle atrophy due to disuse. Option C, epiphyseal overgrowth from chronic hyperemia near the growth plate. Option D, joint contracture causing limb shortening. The correct answer is option C, epiphyseal overgrowth from chronic hyperemia near the growth plate. Chronic synovitis causes persistent hyperemia, meaning increased blood flow adjacent to the growth plate. This sustained vascular stimulation accelerates endochondral ossification and growth plate activity, resulting in overgrowth and limb lengthening. The affected limb becomes longer than the contralateral side. This is the most common growth disturbance in unilateral knee juvenile idiopathic arthritis, particularly in skeletally immature children. Risk factors include persistent synovitis causing growth plate inflammation, periarticular hyperemia, stimulating epiphyseal overgrowth, corticosteroid use suppressing osteoblast activity, joint contracture altering mechanical loading, and epiphyseal bar formation, which causes the opposite effect of limb shortening. Both accelerated and delayed growth can occur depending on the stage and treatment. Before we conclude, I would like to tell you about our Pediatric Case Review community on Patreon. This community contains all our lecture videos arranged by body system, so you can access all videos in one organized place. All presentations used in the videos are also available as high-quality photo decks, so you can read the content and practice all clinical case questions at your own pace. For subscription details and how to subscribe, please comment below in this post, and we will message you with everything you need. Let us review the key takeaways from today's lecture. First, Fever plus acute joint swelling should make you think septic arthritis first and act fast. Second, antinuclear antibody-positive children under 6 with oligoarthritis need mandatory eye screening because uveitis is silent. Third, spiking fever plus salmon rash plus organomegaly points to systemic juvenile idiopathic arthritis, and you must watch for macrophage activation syndrome. Fourth, ferritin above 500 nanograms per milliliter is a red flag for macrophage activation syndrome, requiring immediate escalation. Fifth, ultrasound is the most sensitive early tool for synovitis detection. Thank you for watching. Please follow Pediatric Case Review for more evidence-based, case-driven content. If you have any questions, drop them in the comments, and we read every single one. Thank you for watching and learning with us. We hope this lecture on causes of arthritis in children has been informative and valuable for your clinical practice. Please remember that this lecture is intended for educational purposes only. Clinical decisions should always be based on individual patient assessment and current institutional guidelines. See you in the next lecture.